Assalamu alaikum. Welcome after the forced vacations, we could say, or spring vacations. So we'll continue with our lectures as scheduled, and today we'll be talking about cardiomyopathies. As usual, our format would be discussing a few case scenarios, and then we'll be covering about their uh, clinical features as well as their lab findings. So the first scenario is a 30-year-old previously healthy shopkeeper who has presented into the outpatient department with complaints of progressively worsening breathlessness. He was previously healthy, but for last 2 months he is now complaining of shortness of breath. He denies any previous history of rheumatic fever. He is not a diabetic. He is not hypertensive. There is no history of any previous chest pain, angina, or anything to suggest that he may be having an underlying cardiac disease previously. On examination, his pulse is 90 beats per minute. His blood pressure was 100 over 70 millimeter of mercury. His JVP was raised around 5 centimeter, and there was a very prominent V wave to this jugular venous pressure. His apex beat was located in 6th intercostal space. It was displaced laterally in the anterior axillary line. A short ejection systolic murmur at the apex was heard. There was also a third sound gallop auscultated, and the palpation of the liver suggested a congested tender liver. There was some moderate ascites on abdominal examination, and pedal edema was quite marked. His ECG showed a right axis. There was evidence of left ventricle hypertrophy. On chest X-ray, there was gross cardiomegaly, and there was quite marked heart hilar congestion. On echocardiography, all 4 chambers of the heart were dilated. On Doppler, there was a mild aortic regurgitation, there was mitral regurgitation, some tricuspid regurgitation, and also there was a visible clot in the left ventricular apex, and his left ventricular ejection fraction was 30%. There were also slight increase in urea and creatinine levels. This is his ECG. As you can see, there is right axis, there is also evidence of left ventricular hypertrophy. There is some left ventricular strain pattern, so and slightly intraventricular conduction delay is also visible. This is his chest X-ray. Again, gross cardiomegaly, and you can see say shadowing spreading from the hila to the periphery, and this is which is consistent with the pulmonary edema and heart enlargement cardiomegaly. This is apex echocardiogram. On the left side, you see a 4-chamber view of the heart, and you can see there is a visible clot in the left ventricular apex. This is slightly zoomed or a magnified view. You can also see this clot attached, and you can watch this ECG underneath. Again, this is a zoomed view of apical 4-chamber on echocardiogram, and again the marked dilatation of the left ventricle and left atrium is visible. Now, differential diagnosis of this patient based on his recently rapidly developing heart failure could be just a blanket term like congestive cardiac failure. But as you know, congestive cardiac failure is not a diagnosis. It is just tells you that the heart is dilated, and this is leading on to congestion in the lungs, and the right-sided dilatation or failure is giving congestion into the liver. Again, in absence of any evidence of ischemic heart disease and no evidence of any rheumatic heart disease, although there is no mention of any flu-like symptoms or any fever associated or preceding this illness, we can still post-viral myocarditis can also present in the fever. The most likely diagnosis would be considered as dilated cardiomyopathy. And in next few slides, we'll be talking about what this new dilated cardiomyopathy is. Now, by definition, it is a primary or idiopathic of unknown etiology, which is principally affects the myocardium. This myocardial uh, involvement leads to left ventricular dilatation, and of course, there is a failure of the pump, so systolic function or systolic dysfunction takes place. Uh, in majority of the cases, it is idiopathic, but sometimes we may include secondary causes like ischemia. So if there's a global ischemia, the whole of the myocardium, instead of getting infarcted, starts getting functioning less and heart starts getting dilated. So global ischemia, or what we call the small vessel disease, may not present with symptoms predominant of angina, but maybe of just breathlessness or dyspnea. Alcohol is toxic to the heart or to the myocardium, and it leads to alcoholic myocarditis, and then in the long run it would lead on to cardiomyopathy. We are familiar with the pregnant ladies in their last trimester getting dyspnea, or dyspnea developing immediately after delivery, which is called as peripartum or postpartum cardiomyopathy. Some of the infections may damage the myocardium and can lead on to rapid onset, say, heart failure symptoms, and this can be post-infectious, and particularly the virus are more notorious about that. This form of cardiomyopathy is the commonest one which we see in our clinical practice. Now, this picture is quite suggestive of what happens. So, on your left hand side of your screen, you notice this, say, normal heart. Look at if this arrow is pointing towards, look at the chambers. This is the right atrium and right ventricle, and this is the pulmonary artery, and this is the left atrium, left ventricle, and aorta. Now, the heart chambers, they have two type of function. They relax, and when they relax, they receive blood, or which is called as a diastolic or diastolic filling of the chambers, and then they have to contract and they pump the blood to the respective circulations. The right sided circulation or right ventricle would push or pump its blood to the lungs, and the left sided would be pumped through aorta to the systemic circulation. And look at the chamber size, look at the various, say, the thickness of the myocardium. And now we move on to the right hand side of your screen. What has happened? The heart has dilated. When it is dilated, it would not be pumping forward into the pulmonary artery and into the aorta, and it will not also be able to receive blood, because the chambers are dilated. They are already filled with some blood which was not pushed to the respective circulation and is lying there, and of course they would not be receiving blood. So, but the major dysfunction would be into the uh, pump failure or systolic failure. Now, these are various causes of this cardiomyopathy. As you see, the bar on the left side, in the purple one or blue one, is the most likely or the most common causes, which is, of course, as is idiopathic dilated cardiomyopathy. We don't know the cause, but of course, as we described, myocarditis, ischemic cardiomyopathy, sometimes some infiltrative diseases can lead on to peripartum. We discussed about hypertension to begin with leads on to hypertrophy, and then the dilatation of the ventricles, particularly the left ventricle, and it would produce heart failure. HIV or AIDS can also lead on to myocarditis and some connectivity disorders, and not to forget substance abuse like cocaine or hashish. They can also be reason, but they are very low in number as a result of these problems. So most of the patient, in most of the patient, we don't find any cause for this their heart failure or their pump failure. This is just an example of the two say hearts. The one on the left right is a normal heart, and look at how extremely dilated is on the left side of your screen. And if you get a cross section, the cross section shown on the right, which is very nicely thickened left ventricle, along with this is the right ventricle as the arrow moves on, and look at how what has happened to the heart, which is having a dilated cardiomyopathy. All chambers dilated. The left ventricle is markedly dilated, and so is this right ventricle, which is also dilated. Now, the causes, as you said, mostly are idiopathic, but still there are some genetic factors which are responsible for families having, say, cardiomyopathy running in their family, and there may be other family members or siblings or parents having a similar illness. Viral myocarditis, to begin with, it's a viral infection, viral insult to the myocardium, but in the long run, this then does not recover, and the pump function continues to be affected, and this would lead on to cardiomyopathy. Again, cytotoxic insults or some, say, chemotherapeutic agents like doxorubicin, or they can also damage the myocardium and can lead on to uh, heart failure in the long run. Immunological abnormalities, the beta receptor active antibodies, the beta receptor in the heart are the one which maintain or initiate the contractility. Some abnormal T cell function can lead on to immunological basis for this. And then again, metabolic, energetic, and contractile abnormalities like defective calcium ATPase activity, defective myofibrillary ATPase activity, or low creatine kinase activity. All these which are responsible for, in one way or the other, with the myocardial contraction strength or contractibility, they can be postulated or thought of as a contributor towards idiopathic cardiomyopathies. The presentation usually is with the symptoms of heart failure. The patient would complain of uh, progressively increasing breathlessness, starting from on effort to progressing to a stage when the patient may be dyspneic even at rest, or they may also start experiencing, say, orthopnea and paroxysmal dyspnea. Sometimes there may be an associated angina like chest pain as well. These dilated hearts, since they do not pump blood forward, there is likely possibility of stagnation of blood into the chambers, particularly the left ventricle, where there can be formation of a clot, and this clot then can embolize to any of the circulation, like in systemic circulation, going to brain for causing a stroke, or sometimes they just may be fixed cardiac output which cannot be increased, and on demand, when there is an increased say cardiac output required, patient may, like on slight running or on some activity, patient may faint or may get develop syncope. And similarly, these dilated hearts are their electrical excitability also gets disturbed, and they can develop arrhythmias, and they can develop sudden cardiac death. The diagnosis of idiopathic cardiomyopathy, as we can see, uh, if you do a chest x-ray, you would see a cardiac enlargement as we have shown, and there would be congestive heart failure, or this congestion seen as shadow is spreading from the hilar region to the peripheral, causing a bat wing appearance. And in the later, they may also develop pleural effusions and the upper lobe diversion of the veins. ECG is non-specific. Sometimes it may be totally normal, but mostly the patient show tachycardia. There is AV block of various sorts, starting from the first degree to a complete heart block. Left bundle branch block is quite commonly seen, and then there can be non-specific STT changes, and some premature ventricular contractions can also be uh, expected or observed in ECGs of these patients. If you go for a 24-hour Holter monitoring, particularly if the patient is having symptoms like syncope or palpitation lightheadedness, you may identify certain transient runs of arrhythmias like ventricular tachycardia or maybe short runs of supraventricular tachycardias. Echocardiogram is the mainstay of, say, diagnostic investigations. You would see almost all chambers dilated, but more so it is left ventricle. And in ischemic patients, you have areas of the myocardium which have undergone infarction and they are hypokinesic. This is called segmental wall motion myopathies. But in dilated cardiomyopathy, there would be all part of the myocardium would be contracting less, and to this we call global hypokinesia, and left ventricular ejection fraction would be reduced or low. If you do go for a cardiac catheterization, and this is done particularly in patients who are 50 plus, that there may be coexisting coronary artery disease as well. And if coronary artery disease is suspected, you still can possibly, if you identify an additional coronary artery occlusion or stenosis, you can go for any intervention in the form of stenting or say cabbage may be of help. So if patient is having symptoms of heart failure and is 40 year plus and also have other risk factors for ischemic heart disease, there is history of angina, or has a say other risk factors or an abdominal ECG, he should undergo cardiac catheterization or cardiac angiography. Myocardial biopsy for diagnosis is very, very rarely done in some, say, for research purposes. It's not routinely recommended. The treatment of dilated cardiomyopathy, as we already do, is that you go for some non-pharmacological interventions and you go for then pharmacological interventions. Since they get dyspneic on a minimal activity, so restricting their physical activity or reducing their pace of walking and asking them not to say go say upstairs at a rapid pace, that can be helpful, because as you increase the activity, there's an increased demand of for oxygen, and disfailing heart cannot provide it, and the patient would become symptomatic. Reducing salt would, of course, reduce the circulating blood volume as well, because salt retains water with it. So lower is the circulating blood volume, lower would be the preload, and this would be beneficial, that the heart would be able to pump low circulating volume more efficiently as compared to the one who is have a fluid overload. Restricting their fluid to around 1 to 1.5 liter per day, and that should include all kind of fluids, the water and all rest of the fluids the patient takes. And then the medical therapy. Medical therapy is mainstay is AC inhibitors, which do both, they do primarily reduce the afterload. So if the blood pressure is slightly on the lower side, they would lead on to say the heart would have to pump against lower pressure and it would be able to pump more efficiently. ACE inhibitors also lead on to say cardiac preventing the cardiac remodeling, particularly in the post-MS settings, and they are helpful. Diuretics, as I told, by reducing the preload would be helpful. Digoxin has an inotropic effect, it has a chronotropic effect. It is particularly useful in patients who developed atrial fibrillation because by reducing the, say, ventricular response to the atrial contraction would be beneficial. And hydralazine and nitrates, which is actually an attempt to, by nitrate, you lead on to, say, reduce the preload, and by hydralazine, you reduce the afterload, and both reduction in afterload and preload, it would help the heart to pump more efficiently. Similarly, nowadays there is a new drug there is a combination of angiotensin receptor blocker along with naproxen, or which is another novel agents for the function of the ACE angiotensin converting enzymes. And this combination by the name of this is a combination of valsartan and sacubitril. Now, this combination has gained popularity because it has led on to quite a significant improvement in patient with heart failure, and is definitely can be considered as drug of choice in patient with any kind of heart failure, particularly cardiomyopathy. These patients, as we already said, one of their long-term complication is development of a left ventricular thrombus and formation of clot and embolization. Particularly those who have ejection fraction of less than 30% are at risk of developing thrombosis. So in these patients, you can prescribe anticoagulants, and again, all three types of anticoagulants can be prescribed. You can, in the short term, you can prescribe them with heparin or low molecular heparin like enoxaparin. You can prescribe warfarin, and then you can also prescribe novel anticoagulants, which is direct factor 10 inhibitors like rivaroxaban. Another problem with these patients is an increased risk of developing arrhythmias, and most of the time these arrhythmias can lead on to sudden cardiac death, and the most notorious or most dangerous one is ventricular fibrillation. So these patients may be planted with implantable defibrillators, and so that if any arrhythmia occurs, this implanted defibrillators detects it and give say immediate DC cardioversion, and any casualty is prevented, and patient may survive. The mainstay, because with all these measures you can possibly maintain them into say a good clinical status and free of heart failure. But the long-term management is possibly, since this heart's markedly dilated, very poor function, and all you can do is by reducing preload and afterload and giving them some inotropic supports, you can maintain a certain level of activity, but not more than that. So when there would be possibly a possibility of cardiac transplantation. In fact, idiopathic cardiomyopathy in relatively younger people is the most common indication for cardiac transplant. Survival of a transplant is around 80% 1 year survival, and 70% do survive 5 years. And if that cannot be done, there are some say centers which are practicing that say ventricular size to be reduced by left ventricle reshaping surgical procedures. Again, not been very commonly practiced and available in limited centers. So this is about dilated cardiomyopathy. Now we have another case scenario. This time this is a 16-year-old boy, and he is complaining of very frequent attacks of fainting. He develops blackouts while playing with his classmates for the past 3 months. His elder brother died suddenly while playing squash at the age of 22. So he's young, in fact, quite juvenile or in his teenagers, and with the history of a family history of someone having a sudden cardiac death in the family. And now he's complaining of primary complaint is not dyspnea, but off and on spells of fainting. On examination, his pulse is 88 beats per minute. Carotid pulse has a very particular jerky type of a character, that there is a abrupt rise and then there is a, say, like it's felt like a jerk. Apex beat is in fifth intercostal space, and again there is, it's felt like as if a double apex beat or double apical impulse. Systolic thrill is palpable at the left parasternal border, and grade 4 by 6 harsh systolic murmur at second left intercostal space, and this murmur gets exaggerated by applying doing a Valsalva maneuver. ECG of this patient showed abnormal Q waves, particularly lead 1, AVL, and V4 and 6. There were few VPCs or ventricular premature contractions noted. Chest X-ray was unremarkable. On echo, an asymmetric septal hypertrophy was noted. The septum was more than 1.6 times thicker than the posterior wall. There was prominent systolic anterior motion of the mitral valve, and there was a gradient noted in the left ventricular outflow tract, which was around 90 millimeter of mercury. This is a picture of a parasternal long axis view, and what you notice is that this is aorta, right? This is left atrium. This is, say, mitral valve, and there is a very trace of during systole, when the blood is flowing from the left ventricle to the aorta, there is some blood going back into the left atrium, which is very trace mitral. But the main thing noticeable is that you note this very high turbulent flow over here. Now, this turbulent blood flow is as a result of that there is some narrowing below the aorta, and when the blood passes through, has to overcome this obstruction, it produces a lot of velocity. This is what is called the left ventricular outflow tract pressure gradient, that between this area and this area there is a pressure difference of around 90, and this is what is responsible for this mosaic type of pattern seen in the left ventricle outflow. This is again a parasternal long axis view in the upper column, where you can see this is the line from which we are recording this lower part, and this is during say diastole, the mitral valve is open, and during systole the mitral has to be closed. So this is the anterior leaflet and this is the posterior leaflet. Of course, during diastole they have to be open, but during systole, notice that this say anterior leaflet is pulled towards the septum. This is what is called as a systolic anterior motion of the mitral leaflet. And why it happens is that if you recall that if there is a very high velocity of blood or velocity of say even air passing through some say space, it pulls the structures which are say adjacent to it. Just we give an example that if you are standing at a platform in the on the railway station, and when the train passes by you at a very high speed, it tends to, the air which is moving tends to take people pull along with them. Now this is the same phenomena, that when blood is high velocity blood flowing from the left ventricle to the aorta, so this pulls the anterior leaflet of the mitral valve along with it. So this is anterior motion of the mitral leaflet would leave this area a bit open during say systole. there would be some degree of mitral regurg taking place, which would be very insignificant. So this is what happens in systolic anterior motion. A differential diagnosis, if someone who is having, say, blackouts or syncope or fainting or who falls during or after exercise, includes, it's a simple syncope, which can be vasovagal, which can be hypovolemia, which can be because of bradycardia occurring as a result of many things. It can be considered as a transient ischemic attack, that there is a decreased blood supply to the brain, which is responsible for some global ischemia and loss of transient consciousness or loss of transient function. But in younger people presenting like this, the hypertrophic cardiomyopathy should be the main thing to be considered. What hypertrophic cardiomyopathy is? It is the prevalence of hypertrophic cardiomyopathy is 1 in 500 100,000 individuals. Previously, many of these patients were not, say, diagnosed, and the incidence or prevalence was thought to be very less. Particularly, it is more common in black, and in there, again, it's more common in, say, men, and as compared to the white people, the black people have almost 2 times more incidence of having hypertrophic cardiomyopathy. It occurs with the same frequency in almost all part of the world. The pathophysiology of hypertrophic cardiomyopathy involves 4 processes. The one is that left ventricular outflow tract obstruction because of the hypertrophic the septum. The second thing is that this hypertrophic, say, left ventricle particularly, is unable to relax, or the left ventricular cavity size is quite small, so diastolic filling is impaired and there is a diastolic dysfunction. Of course, this too much thickened myocardium, of course, would have more demand for the oxygen supply, and since the supply has to come from the epicardial vessels, so the distal or innermost portion of the myocardium may not have adequate blood supply, and there would be resulting myocardial ischemia. Then, as we said, partly because of this systolic anterior motion, there would be mitral regurgitation as well. This diagram again shows a normal heart and a hypertrophied heart. On the right side of your screen, this is a normal heart. Look at the chamber size, look at the septum. This is left ventricle mainly, this is the left atrium, this is the mitral valve, and this is right. And down you see how nicely these myocardial fibers are seen on, say, histopathology. Now, this is a hypertrophied, say, heart. Look at, there is all parts are hypertrophied, but look at this, the septum. Septum is much more, say, hypertrophied as compared to posterior, and this results in a very small narrow cavity, right? And look at this, the type of the hypertrophied muscles which are seen on right. So the histopathology shows that there is myofibrillar disarray, and of course there's an interstitial fibrosis, and there is massive left ventricle hypertrophy, which is more marked towards the septum. Clinical presentation, mostly they may start developing dyspnea on exertion. They would also have orthopnea, peristaltic dyspnea. Some of them may complain of angina, not because of the congenital coronary disease, but maybe because of this markedly thickened myocardium requiring more blood for its, say, oxygen demands, and which cannot be. But the more commonly they present with syncope or pre-syncope or a very transient brief loss of consciousness, because when there is on exertion, this contractility further increases and leads on to further narrowing of the outflow tract and decreased blood supply to the, say, vital organs, and this results in. And again, one more thing to be afraid of is that these hypertrophied ventricles are prone to have arrhythmias, and these arrhythmias can be a reason for their sudden cardiac death. So this is by far the commonest cause of sudden cardiac death, particularly in young people and in athletes. On examination, the carotid pulse, as we described, is bifid, that the ventricle pushes some blood in the initial systole, and there is a lot of pressure difference, and it produces a slight weak pulse, and then in the end of systole it exerts more, so you have a jerky type of a carotid pulse. JVP would show a prominent A wave because of a decreased ventricular compliance. Apical impulse usually is like called a seesaw movement, that you have a double apical impulse. Initial contraction pushes some, moves some the apex toward the chest, and then later on there is an additional force which tries to give an impression of that the apex strikes twice to the chest wall. The most common oscillatory abnormality is fourth heart sound, but in addition there is a harsh systolic murmur, usually oscillated at the left, say upper second left intercostal space. The murmur is like a medium pitch. It's a crescendo, decrescendo, left lower sternal border without any radiation. And if you ask the patient to perform a Valsalva maneuver or ask him for squatting, the murmur intensity increases. The another murmur which has a similar quality and has a similar increase in intensity is because of mitral prolapse. But in that you may also auscultate an say mid-systolic click in patient with mitral prolapse, which is not auscultated in patient with hypertrophic cardiomyopathies. ECG, echo, and catheterization all are indicated, and they are done. This is there are a few examples of this ECG abnormalities. As I said, there may be some degree of say left ventricle strain pattern, which in the form of ST depression or T wave inversion, as is evident on this patient. There may be chaotic or bifid or biphasic type of T waves. This can be expected. Again, another patient which suggesting of a picture like subendocardial myocardial infarction or non-QMI infarct like pattern, which is again just a T wave abnormalities. But the most say universal finding which is found is a very abnormal Q wave. This Q wave has been particularly called as a dagger-like, or like a जैसे खंजर की तरह से, right? So this is the prominent Q wave, along with some STT changes, and this may be considered as say ischemic, but in absence of any history of chest pain, in absence of other risk factors, and in patient presenting with the syncope-like picture, or a patient presenting with recent onset dyspnea, you should consider hypertrophic cardiomyopathy as a cause. This is another example of a patient with say hypertrophic cardiomyopathy, and then there can be, as I said, various type of STT changes along with. So the findings in ECG in these patients, they may have nothing on ECG in 10 to 15% of patients, but almost 85 to 90% of these patients do have some abnormality on ECG, which can be in the form of left ventricular hypertrophy pattern or a strain pattern, abnormal STT changes, joint T wave inversions, abnormal Q waves. They may show up bundle branch block. There may be an evidence of left atrial enlargement, and there may be ventricular arrhythmias associated with it. The disease progression in hypertrophic cardiomyopathy is that if this thickness of the arrow, this is what suggests what is the percentage of patients getting which course. So many of them may remain stable and may have a benign course and may not even be diagnosed. They may have so subtle or so minimal symptoms. But the main profile of these patients is that they are at risk of developing sudden cardiac death. They are at risk of developing atrial fibrillation. They have symptoms progressive heart failure or syncope, and few of them may go on to the end stage heart failure or frank dyspnea, pulmonary edema, and of course, as we also said. So this is the thickness that majority would have an asymptomatic course. Some would develop atrial fibrillation, so can be considered as one cause of atrial fibrillation. Few would may have sudden death, and then maybe progressive symptoms, and finally heart failure. The most feared, say, say, outcome in patients with this hypertrophic cardiomyopathy is fear of sudden cardiac death. So it is more common in adults less than 35 years of age. It can be resulting from ventricular fibrillation, ventricular tachycardia, and usually these people unfortunately die while they are actively having a vigorous physical activity. And sometimes this can be the only first manifestation of the disease. It is more common cause of sudden cardiac death in competitive athletes. Other possible events, as I said, risk factors for this cardiomyopathy or sudden death, can be development of atrial fibrillation or development of myocardial ischemia or high risk, say, unexplained syncope. The natural history of cardiomyopathy is that they would, in the long term, if they survive for a good length of time, they would develop heart failure. But as I said, only 10 to 15% progress to NYHA 3-4. 3% will become truly end stage with systolic dysfunction, and there is risk of developing endocarditis with hypertrophic cardiomyopathy because of high velocity jet in the left ventricular outflow, and 4 to 5% of the patient of hypertrophic cardiomyopathy may develop endocarditis, and usually the valve affected is mitral valve. They can develop atrial fibrillation, and 30% of these patients of hypertrophic cardiomyopathy at some stage will develop atrial fibrillation. This development of atrial fibrillation depends upon that this patient would become more symptomatic, because if you lose the final atrial kick as a result of atrial fibrillation, it will further reduce the cardiac output, and the patient will become more symptomatic. They may have some autonomic dysfunction in the form of tachycardia, palpitation, or other, right? So 25% of the patients may just present with these symptoms. But development of these autonomic dysfunctions, particularly the worsening of syncope or other autonomic abnormalities, points towards a poor prognosis. The therapy for hypertrophic cardiomyopathy is medical therapy. Then there are some devices which are used. Then surgical septal myotomy or alcohol septal ablation will discuss one by one. So if you look at the overall population who have this hypertrophic cardiomyopathy, some of them are at risk of sudden cardiac death, and these patients would be prevented by implanting implantable cardiac defibrillators. Then genetically affected phenotype, so they may not have symptoms. And if there is a family history of having someone in the family, they should have a longitudinal follow-up. Now, a group of patients with the hypertrophic cardiomyopathy will develop either atrial fibrillation, and these patients would require cardioversion, use of digoxin, use of rate controlling, and of course, these would require anticoagulation as well. Those who develop progressive heart failure, they would have to be treated with drugs like verapamil, beta blocker, and antiarrhythmics, or they would be, if there are no symptoms and low sudden cardiac risk, they may not be requiring any medication, can be just followed up as such. But those who, despite this drugs, remain symptomatic, then you have to think of some non-obstructive hypercardiomyopathy. They just maybe advise rest and some provocatants, and you can use afterload reduction, diuretics, digoxin, beta blockers, and spironolactone. And these are the individual who, if are refractory to medication, would finally, after the medication failure, would go for a heart transplant. The other category, which are refractory to symptoms and have obstructive symptoms, they may be kind of, so the one which are having more of a heart failure symptoms would be for medical management and transplant, and more with the obstructive symptoms like syncope and fainting, they would be the one who can be considered for septal myotomy, and alternative surgery can be triple, uh, pacing, and of course, sometimes we can go for alcohol septal ablation. So, beta blockers, they increase the ventricular diastolic filling relaxation. Hypertrophic cardiomyopathy are useful. They remain the mainstay of treatment. They also decrease myocardial oxygen consumption, but they have not shown any benefit in reducing the incidence of sudden cardiac death. Verapamil it augments ventricular diastolic filling and is considered as a good drug for treating these patients. Disopredamol is used in combination with beta blockers, and it would, of course, reduce the risk of arrhythmia, but at the cost of being negative inotropic. And of course, diuretic would also be helpful in reducing the preload, and when there is a dyspnea, more prominent feature, it would be helpful. Arrhythmias can be, say, treated by placing a dual chamber pacing, and this would lead on to, say, reducing the risk of arrhythmias. But as far as long-term prognosis is concerned, or as far as the survival is concerned, there has been no correlation between putting a pacemaker or producing a left ventricle reduction, left ventricle outflow tract gradient. So the symptoms of heart failure would also be needed to be addressed through medical measures. This is what we can do in septal myotomy. So look at the septum. It is quite markedly hypertrophied, and if you chop off this part of the septum, you can result in an improvement in the space which is there for blood to flow from the left ventricle to aorta. This is what we can do is that if this part of the septum is supplied by a small branch of the left ventricle, which is called the septal twig or septal, right? So this first septal perforator, or so if we block this vessel, this will lead into a very small controlled type of infarct of this area of the myocardium, and rest of the myocardium remaining safe and without any interruption of its blood supply. So if you produce through this cardiac catheterization, you inject alcohol or any other substance into it. Sorry. So this would lead on to, say, infarct, and this infarct would reduce the thickness of the septum and would improve the left ventricular outflow tract obstruction. Now this is what we can achieve through various interventions in patients with hypertrophic cardiomyopathy. A third case scenario is a 20-year-old young female presented with progressively increasing abdominal distension and ascites and edema for last 3 months. There are no urinary complaints. She is normotensive. On examination, she has mild dyspnea and has elevated jugular venous pressure. There is the normal first and ultrasound were audible, and there was a faint systolic murmur audible at the apex. Liver was markedly enlarged. It was 7 centimeter below costal margin with a total span of around 25 centimeters. And there was a fluid thread in the abdomen suggesting there was free fluid. And of course, there was marked 3 plus pedal edema. The differential diagnosis of such a patient who presents with ascites and edema would be either it can be fluid detention as a result of decreased oncotic pressure because of nephrotic syndrome or a protein loss in the urine and hyperproteinemia. Sometimes hepatic vein fibrosis leading on to massive liver enlargement and ascites like in Budd-Chiari syndrome. We commonly see patient with ascites and edema as a result of cirrhosis. But one of the cardiac cause of such picture can be constrictive pericarditis, and then it can be restrictive cardiomyopathy. By restriction, we mean that the myocardium does not relax to receive the blood. There is so much of a fibrosis that it behaves like in constrictive pericarditis. It is the outer membrane which is thickened, but here the membrane is okay. The myocardium itself has undergone some kind of a change as a result of fibrosis or infiltrate that it does not relax. This was that patient's chest X-ray. They're showing some cardiomegaly, but more prominently, it is the pulmonary edema over here. This is another patient who has right pleural effusion. Echocardiography of this lady, as you see, it was unremarkable as far as the chamber size or valves are concerned. Ejection fraction was okay, but there was marked dilatation of the atria, biatrial dilatation, normal biventricular internal dimension systolic function, restrictive pattern of left ventricular diastolic filling, and abnormally slow or echogenic blood in the right atrium and inferior vena cava. There's mild pulmonary hypertension. This is a very characteristic picture of apical four-chamber view of a patient. So this is the apex from where we are seeing. Look at these two small chambers above. These are the ventricles, left ventricle and right ventricle. And look at the hugely dilated atria. Why? Because this part of the myocardium, which is the ventricles, that has undergone some fibrotic change, or it does not relax. So the atria has to push forcefully to push blood from the left atrium to the left ventricle and from the right atrium to the right ventricle, which results in marked dilatation of the atrial chambers. So this is restrictive cardiomyopathy. The hallmark is abnormal diastolic function. The ventricle wall is rigid and there is impaired filling. As we said, resembles to constrictive pericarditis, but in that it is the pericardium which has undergone fibrosis and restriction, whereas in constrictive pericarditis, it is restrictive cardiomyopathy. It is mainly the myocardium which has undergone the fibrosis. So it has to be differentiated because in restrictive, say, cardiomyopathy, nothing much can be done. But for constrictive pericarditis, chopping off that pericardium and relaxing the chambers can be quite beneficial. As compared to the other two types we described, dilated cardiomyopathy or hypertrophic cardiomyopathy, it is quite less frequent, and it is more commonly seen in Africa, in some part of India and South and Central America. And because these regions have, say, increased incidence of endomyocardial fibrosis as well. Now, it can be classified that it can be idiopathic. There will be myocardial factor like non-infiltrative idiopathic scleroderma is one condition where there is fibrosis of all the connective tissues and can involve the heart as well. This myocardium can be infiltrated by certain other substances like amyloid, like sarcoid, like Gaucher disease or other disease, where it is infiltrated and the myocardium is replaced by more of those infiltrated material which does not let it relax. Storage disease like hemochromatosis or glycogen storage can also be one reason for this restrictive myocardium or restrictive cardiomyopathy. Endomyocardial fibrosis, hypereosinophilic syndrome, carcinoid, malignancies, radiation, anthracycline, they all lead to endomyocardial fibrosis, and this can be presenting as restrictive cardiomyopathy. The clinical manifestation are usually of the right and left heart failure. In fact, pump is not failing; it is the atria which have the main burden. So this left atrial enlargement would be responsible for congestion in the lungs, and the right atrial enlargement will be reason for congestion in the liver and massive ascites and edema. How to differentiate between restrictive cardiomyopathy and constrictive pericarditis. In constrictive pericarditis, there is sometimes history of tuberculosis, trauma, or any pericarditis in the form of any pain, and they may also be having some evidence of collagen vascular disease. But in restrictive cardiomyopathy, where there may be history of having an underlying disease which can lead on to myelinosis, or there can be infiltration like in hemochromatosis, and sometimes there may be history of mediastinal radiation, which can be a reason for restrictive cardiomyopathy. Treatment, we don't have any satisfactory treatment for this condition. Supportive medication like diuretics may reduce some filling pressure and can be improvement. Vasodilators may reduce, say, preload. Catenin blockers can also improve some diastolic compliance of the ventricle. Digoxin and other inotropic agents would not be of much benefit. Now, this is a summary of various cardiomyopathies. So we can have hypertrophic cardiomyopathy, we can have dilated cardiomyopathy, we can have, there is a particular, we did not touch that, arrhythmogenic right ventricular cardiomyopathy. Sometimes cardiomyopathy can be restricted to the right ventricle alone or right-sided cardiomyopathies, and some unclassified. Similarly, the cardiomyopathy may have a familial basis, particularly there may be some unidentified genes responsible for that, and there will be some disease subtypes, particularly the hypertrophic cardiomyopathy are more likely to have familial basis, and then there will be non-familial like idiopathic or disease subtypes. This is just two major types of cardiomyopathy being described. So cardiomyopathy is type of heart disease in which heart is abnormally enlarged or thickened or stiffened. Enlarged in dilated cardiomyopathy, thickened in hypertrophic cardiomyopathy, and stiffened in restrictive cardiomyopathy. And all these processes leads to reduction in the ability of the ventricle to pump. And the two major types I said, the hypertrophic cardiomyopathy, this is the hypertrophy, small chamber cavity, and less blood flowing. And this is the dilated cardiomyopathy, the chamber is dilated, it is walls are thinned out, and it has both a pump failure forward and a back pressure effect leading on to the symptom of heart failure. Thank you very much for your say patient attendance. I hope if there are any questions, you can write down those questions in your in comments column, or you can put it on your say WhatsApp groups, or I'll be very happy to answer those questions. Thank you very much.